Break down the 5 critical nasopharyngeal airways mistakes that can turn rescue into a non-rescue. Stick around to the very end. Well, exclusive bonus content where we reveal insider secrets about nasopharyngeal airways, insights you won't find in any book that I know of. The combat medic and nurse practitioner. I've seen these mistakes cost lives, airway errors, accounting for nearly a third of preventable deaths in emergencies. Let's ensure that you can avoid them. Section 1. Eyeballing the size. The single most arrogant and dangerous phrase in field medicine is, it looks just about right. That's the same lazy mental math that gets mortars dropped on the wrong grid, turning a fire mission into a friendly fire incident. You hold an NPA and just eyeball it against someone's face. You're gambling that their life is based on a guess. Human anatomy is not. The distance from the nose to the pharynx can widely different from person to person. Get it too long, you're not just tickling their throat, you're ramming a semi-rigid tube into delicate vascular structures of their nasal pharynx. At best, you're shredding the turbinates. Okay? Causing a massive nosebleed that now you have to manage on top of an airway obstruction. At worst, you're stimulating the gag reflex until they vomit and aspirate their stomach contents into their lungs. Or you hit the vagus nerve and cause their heart rate to bottom out. Get too short, and the tube is completely useless. It provides a false sense of security, making you think that you fixed the problem, but in reality, it'll just double back in the nasal passage like a cheap, kinked garden hose, creating a new obstruction right there while you're trying to clear one. This fix is non-negotiable. A sacred ritual you perform every single time. Measure the tip of the patient's nose or the angle of the jaw to the ear. When you insert it, if it doesn't glide with a simple, persistent twisting pressure, you stop. Don't force it. You back it out, you relube, and you try the other nostril. Or grab the size down. Your ego and bragging rights about sinking a 28 French cat on the first try doesn't trump the fundamentals or getting an established patient airway. Are your first aid kits actually ready for real emergency? Learn the 5 IFAC. Are your emergency kits ready for an emergency? Are your first aid kits ready for a real emergency? Learn the 5 IFAC mistakes that could cost lives and learn how to fix them with combat-tested prepping advice. Section 2, mistake number 2, shoving it in dry. Let's talk about friction. Instead of inserting a dry nasopharyngeal airway into a naval passage, it's like trying to load a sand-filled magazine in your rifle during a fire. You might, with enough brute force, get it seated, but the damage will lead to catastrophic malfunction down the line. The delicate mucosal lining of the nose is incredibly fragile and rich with blood vessels. It's not designed for dry, abrasive friction. Forcing a dry tube will tear that tissue. It will bleed, often profusely. Now you've taken the patient whose only problem was a mechanical airway obstruction from their tongue and give them a second, more complicated problem. They're still not breathing right. Now they're drowning in their own blood because you've introduced that into their airway. The new bleeding can clot and form an even more stubborn obstruction than the one you were trying to fix. Let's fix this. You people skip it in the heat of the moment. Lube it up. Use water-based lube like Surgilube. Okay? That comes with it. Lidocaine jelly if you're so clear to use it, or even the patient's own saliva if you had to in the most dire situations. Generously lube the entire tube, especially the bevel. Gotta keep that lubed up, baby. Remember, technique. Aim for the right nose, nearest if possible, with the bevel of the NPA facing the septum. Okay? You want the bevel facing the septum. like so. This orientation allows the tip to follow the natural floor of the nasal cavity instead of rigging and digging into the turbinates below. Use a steady corkscrew-like twisting motion as you advance. If you meet firm resistance, stop. This is not a battering ram. Switch sides. Don't transition into Captain Caveman with a spear, turning a simple procedure into a bloody, irreversible mess. Watch. Bevel. Slowly twist. We are meeting some resistance. There we go. Insert it. We got it. Revolutionary stealth hunting tactics using e-bites and night vision technology. Watch my video. Hunt silently at night. E-bite stealth tactics at work. As I reveal silent hunting methods that outperform traditional approaches for deer, coyote, and hog hunting. Revolutionary stealth hunting tactics using e-bikes and night vision technology. Watch my video, Hunt Silently at Night, e-bike stealth tactics at work, as I reveal silent hunting methods that outperform traditional approaches for deer, hog hunting, and coyote. Section 3, ignoring the red flags. A nasopharyngeal airway is not always the answer. There are big, bright, flashing red lights that should scream no-go. And ignoring them is willingly walking into a prepared ambush. The most critical contraindication is evidence of mid-face or head injury, specifically a suspected basilar skull fracture. What are the signs? Look for cerebral spinal fluid, a clear water fluid that looks like nasal drip but isn't, and it's linking from the nose or the ears. Look for panda or raccoon eyes. That's bruising that develops around both eyes without any clear indication of trauma. It's caused by a blood spooling from a fracture in the soft tissues. Look for battle sign, which is bruising that appears behind the ear, or if the patient has obvious catastrophic facial trauma, where the face is unstable and feels crunchy to the touch. If the nasopharyngeal airway is absolutely 100% fit, why? You can't use it because the floor of the cranium in that area, the cribriform plate, is a thin, fragile, perforated piece of bone. In a patient with this fracture, that plate is compromised, forcing a nasopharyngeal airway into a punch that can clean through the fracture site right into the frontal lobes of the brain. You'll be inserting a foreign object directly into the central nervous system. Let that sink in. When these signs are in play, your plan A is out. Default to alternatives. Go back to basics with a simple jaw thrust maneuver or a more definitive airway. Oropharyngeal airway, they have no gag reflex, cricothyroidotomy. Far better for the patient to have a scar from their neck, a plastic tube lodged in their brain. Think you can survive alone? Lone wolf dies, but the pack survives. Watch my video, Why Lone Wolves Fail. Survival secrets that save lives, and discover why team-based survival always outperforms solo tactics. Straight from my combat-proven experience and real-world prepping. Watch now for the secrets to building an unbreakable survival network. Mistake number 4. The drop and run. You did everything right. You measured, you lubed, you checked for contraindications, you slid that nasopharyngeal airway in. You hear the beautiful sound of air moving freely. The patient's color improves from a dusky blue to a healthier pink. So you move on to the next injury feeling like a hero. This is the drop and run. The gurgling stops. So you move on to the next injury thinking like a hero. This is a drop and run, and it's subtle but a deadly trap. An unsecured nasopharyngeal airway will migrate. A little bit of sweat, a little bit of blood, a little bit of tears. Blood, sweat, and tears. Jostling movement during a carry or transport, that tube can and will slide out, leaving your patient right back to where they started with a blocked airway. By the time you notice, could already be hypoxic or an aspirate. You must secure the airway as established. The simplest way to tape the flange on the patient's nose or cheek, like you're anchoring a urinary catheter. Use good aggressive tape. If you have a commercial tube holder, even better. But securing it is only half the job. You have to communicate its presence. One piece of tape, the forehead or chest, and write down the critical information. Nasopharyngeal airway, 28 French. Right nares, inserted at centimeters, for example. You hand that patient down to the next level of care, you want to shout it, okay? Make sure they got that information. Patient has a 28 French NPA in the right nostril. And the next prepper, the next physician assistant, or the next nurse practitioner, they all need to know what's in there, what size it is for suctioning, and where it is, because deep inside a dark bloody airway, a plastic tube can feel like a clot or damaged tissue to a suction catheter. An unsecured, undocumented airway is airway waiting to fail. Your home's biggest threats aren't dramatic disasters. The everyday system failures that can happen right now. Watch my video. You fix these home disasters before it's too late. Suburban Prepper reveals home safety failures most suburban families ignore until it's too late. Combat tested solutions. Common problems. Section 5. Bad head game. Bad head game. This is the final and perhaps most fundamental mistake. You can drop the most perfectly timed, lubricated, and secured nasopharyngeal airway in the world. But if the patient's head is in the wrong position, you've accomplished absolutely nothing. You can't ignore physics. You can't ignore anatomy. If the neck is bent forward, the chin crushed down against the chest like a sad crescent moon, the airway is still kinked, shut further down line at the level of the pharynx. You've opened the front door with the NPA, but the main hallway is collapsed. Air still isn't getting to the lungs. It's like putting a new filter on your gas mask and pitching the hose shut. The non-trauma patient, you want to sit them in the sniffing position. This means tilting the head back, lifting the chin. This means tilting the head back and lifting the chin, which aligns all the structures of the airway, and it aligns them. The pharynx, the larynx, the trachea, into the straightest position possible. Think of creating a super highway for air. Had to try it. Your visual cue is getting the patient's ear over their sternal notch. However, if there's any question of spinal injury, if they fell, got in a wreck, or took a blow to the head, don't tilt the head. Maintain C-spine neutrality, keeping the head in a neutral inline position. From there, your only move is the jaw thrust, keeping your fingers keep the jaw forward without the neck. As always, remember that physics beats a fancy kit every time. Your primary job is to create a straight pipe from the outside world to the lungs. The nasopharyngeal airway is just one tool to help you do that. Don't let it give you a false sense of security while ignoring the most basic principle of airway management. A soldier died in Afghanistan because of a chest rig mistake. Don't let this happen to you. Watch my video, 5 chest rig mistakes that could kill you. The Suburban Prepper reveals 5 deadly errors and how to build the perfect tactical setup. Bonus intelligence that you won't find in books. Tailoring techniques for unique patient needs. Pediatrics, children. Smaller, gentler, comfort is key. When working with pediatric patients, remember their size is smaller and developed anatomy require extra care and precision. Use appropriately sized equipment and tools and always prioritize their comfort to reduce anxiety. A calm, reassuring demeanor make the world of difference in gaining their trust. Be mindful of their heightened sensitivity to pain and adjust your approach to be as gentle as possible. The elderly, fragile skin, complex anatomy. Elderly patients often present unique challenges due to the fragile skin, reduced elasticity, and underlying conditions like osteoporosis or arthritis. Handle their tissue with care to avoid tears or bruising. And be aware for functional anatomical changes caused by age-related factors. Take extra time to assess their medical history and current medications, as these can impact procedural outcomes. Trauma. You want to protect the spine. Expect bleeding. Trauma patients require immediate and focused attention. Always assume a spinal injury until proven otherwise. And take precautions to immobilize the spine during assessment and treatment. Be prepared for significant bleeding and prioritize hemorrhage control. Quick thinking and adaptability are crucial, as trauma can cause the situation to evolve rapidly and unpredictably. You need to adapt your technique for every patient, okay? No two patients are the same. There is no one-size-fits-all. It doesn't work that way in healthcare, folks. Whether it's adjusting for the fear of a child, or the elderly's fragility, or the urgency of trauma, your ability to adapt will ensure better outcomes and higher standards of care. Here's a general guide for nasopharyngeal airway sizes based on age groups. Keep in mind that these are approximate recommendations, and individual patient anatomy should always be assessed. For neonates up to 1 month old, a 6 to 8 French nasopharyngeal airway. Use the smallest size available, as neonates have a very narrow nasal passage. Infants 1 month to 1 year use an 8 to 10 French. Of course, be careful with inserting, as infant nasal passages, again, are delicate. Lubrication is essential to reduce discomfort and risk of injury. The toddlers, age 1 to 3, choose a size that fits comfortably without causing obstruction. Measure from the nostrils to the angle of the jaw to ensure proper length. The children, 4 to 8, use a 12 to 14 French. These young children may tolerate larger sizes, but always confirm the fit and monitor any signs of discomfort or obstruction. The preteens, 9 to 12, use a 14 to 16 French. As children grow, their anatomy becomes to that resemble of adults. Use a size that provides adequate airflow without being too large. The teens and adults, 16 French to 28 French. At this point, the size is determined by individual anatomy other than age. Common adult sizes range from 20 to 28. Male often require larger sizes than female. Just so you know, this is a 28 French here, folks, just so you know. Length. So let's go over this again. How to select the correct NPA nasopharyngeal airway size. Measure from the tip of the nose to the earlobe, like so. Or from the tip of the nose to the jaw down here. I've always been taught to go tip of the nose to the earlobe. Can't go wrong that way. This ensures that the nasopharyngeal airway is long enough to reach the pharynx without being too long or causing complications. Choose a diameter that fits comfortably without excessive force. The NPA should fit comfortably with lubrication. It's a little twisting, okay? Listen, if any of this resonated with you, and a light bulb, went on, I want you to do something for me. Go to the comments section and type in the word measured. That's it. Just write the word measured. It's not for me, it's for you. It's a way for you to make that mental commitment that you will never eyeball an airway again. It tells me you weren't just passively watching or nodding along, but that you are actively integrating this into your skill set. And if you're serious about being an asset when things go sideways, SHTF, about keeping yourself out of court and, more importantly, keeping your patient out of the cold drawer, then hit the subscribe. Listen, folks, I want to thank you for watching. I'd like it if you would like and subscribe. I really would like it a lot. Leave a comment. Remember, do it for yourself. Type in the word measured. That's it. That's it. 5 simple, common, and utterly devastating errors that can turn a hero into a villain. Let's recap some of them so they're burned in your brain. 1, eyeballing the size instead of measuring. 2, going dry instead of lubing it up. 3, ignoring the red flags of a head injury. 4, dropping it in and running instead of securing it and documenting. And number 5, having a bad head game, forgetting that positioning is king. Nail these 5 principles. Make them an automatic checklist in your head every time you reach for that nasopharyngeal airway. If you do, you will stay the hero you were designed to be. These skills until they become part of muscle. Train these skills until they are muscle memory. Train like people's lives depend on it, because they do. One day, it might be your life depends on your fellow preppers standing next to you. Stay sharp. Watch my video, 5 deadly tourniquet mistakes that kill preppers, and discover the 5 errors that will turn your first aid kit into a liability. Straight from Combat Medic. This is survival. This is resilience. This is Suburban Prepper.